So here's the plan for tonight, folks. We're going to talk about, even though we are dealing with the upper extremities, and as soon as I get this program up on the computer, we'll use it again, the same Muscles in Motion computer. I'm sorry about the delayed start, but that's out of our control. We will, before we pick up the upper extremity muscles, I want to talk about the, what do I want to talk about? Piriformis and piriformis syndrome. I'm going to show you a video that I dug up that is about 10 minutes or so that is really, I think, an excellent tutorial on how to treat piriformis syndrome, which is something that mimics sciatic pain, okay? And then we'll look at the piriformis muscle. We're going to look at the iliopsoas muscle, which is something that Rebecca, sign in by all means, please. Don't forget to sign in, pass it around. July 6th, anybody? Pass it back.
Most of us signed.
Sorry? Okay, well, just make sure. Okay, I have to log into, let's pause this for a minute. All right, here we go. We are. Okay, there are, let's dig up my notes here. It's too bad we can't use this thing too. This is a nice illustration. You know, if we could use this and this at the same time and toggle back and forth, that would be good. But I guess that's not it. Okay, the piriformis muscle. Why am I bringing up the piriformis muscle? Because we're supposed to be focusing on the upper extremities. Because I think we have enough time to do the upper extremities before, no one will answer, before the end of the term. Yeah, I will. Okay. Thank you. The screen cometh down. We are going to stop at 9. No, I'm sorry, 8:30. Maybe a little bit before. And I need somebody to go downstairs and maybe a couple of people to run the laundry. There should be leftover towels in the dryer. They're probably still there. So fire up the dryer again and put in a wash. Okay, 2 people.
I'll go.
Okay. Jenna?
Yeah.
Want to go now?
I was gonna say.
Yeah, because I want to get it going. Okay?
Okay.
Because it just never stops. Wait, Bill's going.
Is it open?
Yes, well, they said they were opening it. Who's going?
I think Natalie was doing it, but I'll...
Yeah, right.
Oh, who else went?
Yeah, Natalie, you're right. All right, go.
You gotta love Bill.
That was good.
That was funny.
That was really good. Oh my goodness.
You gotta love him.
Okay. So let's see. So what happens? Again, the reason is I've been seeing, for whatever reason, maybe it's just the nature of our society, we're sedentary, whether there's sports injuries or not. Oh, I have your crystal book you wanted to see. Was it?
It was us, yeah.
Oh, I'm sorry. Whoever it was, not sure. Just remind me. Okay, I think it's a type of quartz. Okay, crystal Bible. Right? Okay, during the break. So I've been seeing, for whatever reason, a lot of clients who come in with sacroiliac syndrome or issues. Nobody's quite sure what the pain may be coming from. Piriformis syndrome, some issues that are involving lower extremity sciatic-like issues, right? So, and you wanted to talk about, or you brought up the,
Well, it's all connected.
yeah, it is, of course, it's all,
SOAS is a huge,
SOAS is the most powerful,
I mean,
Yeah.
for sciatica, I mean, that's a big issue.
yes, absolutely.
I just thought it would be helpful for people to understand where it's connected and why
Mhm.
because the iliopsoas literally becomes the sciatic nerve as it comes down
Yeah,
around.
yeah, right.
Yeah?
Everything wraps around
So
together.
if you can kind of nip it in the bud from the insertion, if that's where it is, or maybe not.
Or maybe not, depends on what
Depends
it
on
is.
what-
Yeah,
exactly.
yeah. If it is a,
But it's good to know where it inserts and stuff.
yes, yeah, yeah. So we're going to talk about both, okay? I did some work on piriformis syndrome because I seem to be seeing, I don't know if we can see it here, in any case, the hip, the lateral hip rotators, right? Let's look at the entire, right? Here's what they're doing, right? The reason, wait a minute, let me get my, notes in here. And when we get to actually study all the deep lateral hip rotators, I'll give you an acronym to remember them by. Did you learn that one?
The hip what?
The deep lateral rotators of the hip. There are 6 of them. But we'll worry. The only one I'm really concerned about is this one here, the piriformis. The reason being, as it they don't show you the sciatic nerve that's passing through here.
Yeah.
And that's what I'd like to see. Let's see. No. All right, then I will dig up a Whitney Lowe article. Okay. Hang on a second. Oops, nope, no.
Yeah, I can't sit, I gotta keep this.
Let's see if I can just get, We're going to do Swedish, one set, an hour Swedish, okay?
Oh, one person and then the.
Exactly, and then tomorrow night we'll do the other person. Yeah. She's coming in on Wednesday to do Abhyanga, so you have 2 days to do some Googling on Abhyanga, because I'm sure she's going to want to know that you
Bindi test, right?
and a Bindi test, exactly. I'm sorry about this because I want to get to some other websites. So, which is why I got in early today and didn't get into the room. Okay. Okay. See if this works.
No, one of them is different. Only one is the Hawaiian thing.
Yeah, but they go with the forearm. Like, oh,
No, it's
so nice.
no, I think it's different than that, maybe similar. I only know that because I asked. Oh, wait.
Yes, no, maybe.
Slow, very slow. Can you describe what Abhyanga is?
No. As far as I understand it, I'll look it up. It's more four-handed work, so it's 2 people working on one. I think a lot of oil, but I've not taken the time to research it.
I thought we combined
It's
Bindi.
for, well, we did because we wanted to make Bindi go more quickly. We wanted everybody to experience it,
Oh.
right? So that's why she had 2 people on one for Bindi.
That's why I thought we were
Okay.
doing 2 birds, 1 stone.
All right, I
But that was kind
embedded.
of what Abhyanga, I thought Abhyanga was not just, I didn't know.
I don't think
which
it's
one
just
was 4
4
hands.
hands. There's more
I
involved
thought
in that, I
it was
think.
from the bottom all the way to like the whole side.
Right, with a lot of oil.
Ugh,
Yeah. So be prepared to
yuck.
be drenched, and they just got in the order of oil, so we're going to be swimming in it.
Lovely.
But that's
On
it.
Thursday.
Sorry, you know, that's Thursday.
Yeah.
But what about Wednesday? That's
Yeah,
when
Wednesday.
she's.
Well, I'll do something.
Whatever, yeah, I understand. Okay, am I anywhere? Am I in here? Yes, okay. All right, bear with me. Sorry. Come on, let's go.
How do you even spell Anya?
ABHYANGA, I think.
ABHYANG.
Something like that. Is that right? That's right?
Yeah, I'm looking at it.
Okay. So what does it say?
It says, just says large amounts of oil.
Large amounts of oil. So we were right there.
It's a form of Ayurvedic.
Ayurvedic.
Whatever, medicine that involves massage of the body with large amounts of warm oil. The oil is often pre-medicated with herbs for specific conditions. That's a Wikipedia one though. And it's an ancient Indian Ayurvedic oil. Massage therapy for healing and detoxifying body, mind, and spirit. The Ayurvedic detox and stress.
Ayurvedic.
I can't say that word. Reduction therapy is performed by herbal oils. It incorporates an aromatic combination of oils prepared with herbs, warmed, and blended to your dosha type.
There we go.
Spell it again?
Yeah.
ABHYANGA.
Okay.
I start reading that.
Oh, okay.
Sorry?
Return to the master.
Thank you.
Deepak Chopra. Return to the master.
Return to the master. And he's talking about his experience in the School of Medicine in India, that was very occidental.
Yeah.
And then he started getting immersed in the Ayurvedic area.
Thank you.
And he started with it. And that's why he became that.
I don't know if we can get this any larger. So can you see this? What can happen, I don't know if he goes into detail here, but what can happen with sciatic nerves, it can stem from a nerve root, right? From a vertebrae, in which case it has a name, and they call it right. All right. I'm reading Whitney Lowe, which is up there now. Some of the parts that I highlighted. Right. So the piriformis muscle can compress the sciatic nerve. There are a number of other nerves that are traveling through there. You're seeing piriformis. I want to hand here. I'm going to pass this around. I'd like to put this up there, but I don't have. Maybe this is from. Anyhow, pass it around. If I can get this up on the screen, I will. I'll look for it.
Can I take a picture?
Sorry? Yeah, sure you can. Absolutely. You could take a picture. Let's add. Whoops. No. Go away. Okay. And. Go away. Ah, here we go. Okay. Here. This might be it.
Thank you. Thank you. It's okay. Not the wish you want, you want your feet, right?
Let's see.
Oh, we missed
store stuff.
No, you didn't. Yeah, right. Ha 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 ha.
Yeah, we're passing it around.
That was a good one.
You're not Natalie?
But this is where the piriformis is involved in squeezing the sketch. Motion all.
Any handouts?
Oh, yeah.
No. No.
Chairman,
Oops. Ah, sorry about this.
No, go this way.
This one. Okay. This is, what's his name, Whitney Lowe. All right, the thing is that it descends, as you can see, right under, sometimes the nerve itself splits the piriformis muscle. It can be compressed by it there. Other nerves in the region are also susceptible to compression. So if your client is experiencing some sort of lower extremity pain, the superior gluteal nerve could be involved. You need to pinpoint it if at all possible. The gluteal nerve, I think they say, it would not be the gluteal nerve if the pain extended down into the thigh and possibly beyond. The gluteal nerve basically innervates the glutes. So if you've got pain only in the glutes, then it's not necessarily the piriformis muscle, according to my research. Could also be the posterior femoral cutaneous nerve that's adjacent to the sciatic nerve. But what we generally seem to be dealing with is this piriformis muscle. And I want to show you how, let's see, what can I tell you about it other than it's one of the 6 deep lateral rotators. It involves soft tissue entrapment of the nerve, right? If it had come from the spine, well, you need to rule that out, right? If you had some sort of disc displacement, it could be, again, then the sciatic nerve is coming out of the nerve root. Sciatic nerve comes from T, or rather L, it's on the piece that's L5 down to S2 or something, I believe. It's on, what you want to see, it's not this, but that.
Yeah. Okay.
Okay, and if I could dig that up and get that on the screen, but I don't remember where I managed to get it from. Anyway, so what do we do? Let's see. It's a small muscle, right? Here, right? Deep. It's deep within the hips and the buttocks. You're not generally palpating that, but I'm going to show you how you can get in there and affect the issue. It connects the anterior sacrum with the top of the greater trochanter, right? So that's what enables the movement is lateral rotation. And there are, as I said, a series of deep lateral rotators of the hip that all work together. The piriformis, a couple of gemellus muscles, the obturators, and the quadratus femoris. Oops, that goes to our next pizza party. So, those of you who weren't here Thursday, let me put this on stun.
pizza party, I'm listening.
Huh?
It's a pizza party, I'm listening.
Yeah.
Wait, what?
Well, last Thursday, right? Wasn't what's that? And Monday? No. End of the week time. Maybe let Mama buy the next one. So, right. Yeah. Well, she does. She will. Maybe not. No, if she doesn't, I will. Don't worry about it. Right. Okay, so what can cause it? In a minute, I'll show you how to treat it. What can cause it? Exercising on hard surfaces, like concrete, right? Exercising on uneven ground, maybe like the beach, right? beginning an exercise program after a long layoff, increasing exercise intensity or duration too quickly, right? Overtraining, essentially. Overloading the muscles and the ligaments and the joints. Ill-fitting or worn-out shoes, runners and such, right? Sitting for long periods of time, and who does that?
Almost everybody.
Right, almost everybody. This is why probably I'm seeing, and we are seeing, a lot of low back, lower extremity issues such as this, whether it's true sciatica coming from the spine or piriformis syndrome where we're dealing with the constriction of the nerve itself by the inflamed muscle. Okay, let's see. So your mechanics could be off, right? Walking or running, or maybe, heaven forbid, massage therapy mechanics, right? I don't know that piriformis syndrome will be affected by that. No. Tight, stiff muscles in the lower back, the hips, the buttocks, the QL, the glutes, all sorts of things can tighten up for any number of reasons. And then my last note says here, running or walking with your toes pointed out. I'm not sure about that. So what do we do? What do we do the first 48 to 72 hours? Race. Right? Can't really do anything. And if do you want to pass these around? Well, yeah, let's
It's
go.
up to you. I don't know. I can
All right.
run a minute.
I think they're great. I definitely would like people to see them. So this is.
Where'd you get those?
Where did you get these?
I did a workshop on the psoas, and they were selling them. That was a long time ago.
Yeah, the relationships. Start passing it around for people to look at it. In any case, let's see. So after 48 to 72 hours, what do we do? Do you want me to scroll this at all in any particular way?
We could start incorporating heat.
Right, definitely.
After ice,
Mhm.
ice.
Yeah, definitely would start incorporating heat after the initial freezing. Sorry?
I said it's hard to put ice on your butt.
Yes, it is. It feels much better, and most people in general prefer heat over cold, right? Makes sense. Okay.
There's a rule which one apply first. If you are if you're a therapist, can you apply both
Well,
at the same
You
moment,
tell me.
one after another, or something like that?
Not initially.
not
Not
initially. Acute issues, we apply cold. Right? First 48 to 72 hours, we apply cold. So, right? If somebody has an injury, the first thing you want to do is to prevent the inflammation and stop the pain with the cold therapy, not heat.
How it was explained to me,
Yeah,
I
go
don't know
ahead.
if it'll help you at all, is when you have an injury, you have an inflammation, so you put the cold to make it
To reduce the
all the
inflammation.
inflammation. And the reason you bring the heat in is to bring the new blood in to nourish and heal, but you always end with cold. After you do the first 48 hours of ice, then you do ice, hot,
And you do
ice, hot.
contrast.
And it's better to do a wet heat rather than a dry heat. I'm not sure why Elaine probably knows.
I think it penetrates further.
It penetrates, yeah,
Faster?
Further.
Further?
deeper.
Okay, and then you always end with cold, alright, and then, but it's the new blood that heals. So you wanna-
And especially if we're dealing with ligaments and tendons where there's not as great a blood supply, we've got to bring the heat there, right? Now, some people don't like the idea of contrast therapy. I agree. I like contrast therapy, and they generally suggest more heat. What is it, 4 to 1 or something? It may, to a certain extent, depend on the person. I think you need more than a minute of cold of ice. But anyway, the initially,
Great things with ice.
sorry,
I've seen ankles go from.
go down, yeah, immediately,
Just put your foot in a bucket of ice.
and it stops the pain.
Hey, girl. Yeah, because you're so worried about that.
And what do they do? If you see the baseball pitchers between innings with their elbow in a bucket of ice, right? And what happens? I mean, by the time they're done bathing it in that ice bath, It's numb. There's no pain. Right? They go out there, and then of course they throw out the they wind up having to undergo Tommy John surgery for messing up the elbow. Don't
But a lot of
remember.
athletes do the ice baths after a workout.
Yeah.
Not because they have an injury, but just to cool their muscles down and
Mhm.
the inflammation.
But I see, as I said, the pitchers do it in between innings. I guess that's the workouts, and then they have another workout coming up. Yeah. Okay, let's see, what else can I tell you about this? Anatomical variations. They talk about sciatic nerves composed of two divisions, peroneal and tibial. They're usually bound together, but in some cases they divide. They show you that here in figure 2, sciatic variations, right? You could see two divisions here. One is going through the muscle, one is underneath it. Here, the divisions are going under and over the muscle. You see what I'm pointing to? So anatomic variations will certainly make a difference for your client's ability to deal with, or for that matter, even to undergo piriformis syndrome. They talk about, Mr. Lowe talks about myofascial trigger points could be the cause of things. Sacroiliac joint dysfunction can be an issue. In any case, I'm going to call up the video that Muscolino does in just a minute. Let me just read the rest of this through here. Okay. They say piriformis syndrome, muscle is the cause of nerve entrapment, therefore treatment strategies have to emphasize reducing that tightness. You're not about to sit on a bucket of ice, okay? That's not going to do it. It's not going to work. So what you can do is he's suggesting apply superficial effleurage and then generally warming up the tissue. And then treat it with presence and compassionate pressure. He suggests starting with static compression and then applying it, holding it. You'll feel tissue relaxing. And this comes with palpation skills, with practice. But trust me, you'll experience people having these issues, and you can amaze them by dealing with piriformis syndrome and stopping their pain. Let's see. After warming up, relaxing the muscles with broad applications of pressure, you can use small, you can use your thumb, elbow. I definitely sometimes go in there with an elbow. Pressure, I don't use tools, but some people do. Go easy, you don't want to mimic, you don't want to create more pain than is already there. So if that's starting to happen, you need to back off. So you've got to communicate with your client, right? Which, I mean, we may prefer that things be quiet in the treatment room, but when you're dealing with this kind of work, let them know that you want to know if this is painful, right? They talk about muscle energy technique, and I'm going to call up. Let's see if I can go back to here. And Muscolino, where are we? Here. Oh, shoot. Oh, that's not it. Wait a minute. Here it is. It's plenty loud,
Hello,
right?
I'm Joe Muscolino, and I'm going to be showing you palpation of
It's
the
about 10
piriformis
minutes.
muscle.
Well worth watching.
To palpate the piriformis muscle, it's helpful first to locate a few bony landmarks. The bony landmarks that will be important will be the posterior superior iliac spine, the PSIS,
You get those
the
dimples.
apex of the sacrum, and the greater trochanter of the femur. To find these landmarks, it's helpful to place your hands on the client like this, and usually the thumbs naturally land on the PSISs. Here is her right PSIS. To find the apex of the sacrum, begin midline on the sacrum and just drop inferiorly until you feel the joint line between the sacrum and the coccyx. I now have the PSIS and the apex of the sacrum. And to find the greater trochanter, palpate dead center laterally until you feel the bony protuberance of the greater trochanter of the femur. I should also add that normally you would palpate this standing on the same side, but for the sake of the video here, so I don't block the palpation, I'll be standing on the other side of the client. Okay, so the first thing I do, I find her right PSIS, I find the apex of the sacrum. I go exactly halfway between those 2 points. I then drop laterally until I'm off the sacrum. This is important because the piriformis muscle attaches from the anterior surface of the sacrum going to the greater trochanter. If I'm still on top of the sacrum, I'll still be on top of the bone. I won't be able to palpate the actual muscle itself. Once I find this point just off the sacrum, I draw a line from there to the greater trochanter, and the piriformis will be located directly here. To palpate this muscle when it's relaxed, I would want to strum perpendicularly across it. This muscle is deep to the gluteus maximus. It may or may not be easy to feel when you're palpating it without it being engaged. If the gluteus maximus is tight, it would be difficult to palpate it and feel it. If the piriformis is loose, it might be difficult to palpate and discern it deep to the gluteus maximus. To engage the piriformis, to make it easier to feel, we need to have the client do the action that the piriformis does, which is lateral rotation of the thigh at the hip joint. I am going to have her flex her knee joint to 90 degrees. I'll support her here. Lateral rotation is based on the anterior surface moving laterally. That entails the leg, the lower leg, and the foot moving medially.
Medially, right.
So I'm going
See,
to
it's
ask you in just a
confusing.
moment
You get that?
to
Hang
press
on, let me
against
stop that
in
for a
this
second.
direction. I'll have pressure against you right here.
Right? So when we think of that, we have them on the table. They're prone, right? Right? So you're lifting, and we can put this on downstairs if you want to practice it or whatever. So you're thinking lateral rotation. Why am I turning the foot
You want the
medially?
femur to
Because
go
you
out.
want the femur, right, to move, the anterior femur to move laterally. That's the key. Okay? We get that?
Yes.
That was an aha moment, right? For some. Because it can be confusing if you don't see these. All right, let's go on.
Here, do you feel that? So just gently press against me. That's good. Relax there. That's all you need to do. Even a little less. Try it again. Perfect. Relax. It's important that her engagement is not too strong because the gluteus maximus is also a lateral rotator. And if she were to contract hard against me with resistance here, then the gluteus maximus
Would be
would
engaged.
engage, and that would block my ability to palpate through it for the piriformis. Okay, so to show this in steps now, I find the right PSIS, I find the apex of the sacrum, I go exactly halfway between, I drop laterally off the sacrum, I draw a line from there to the greater trochanter, and this is where I'm going to be palpating. I'll do it this way so I don't block your view. Come on up here, and now gently press against me, and there's the contraction, relax. I'll move just a baby step along the line, press against me again, a little harder.
You could practice
there it
this
is.
later
Relax.
when we're doing Swedish.
And I can strum perpendicularly across it. Press again. There it is, good, relax. I'll go another baby step, press against me. There's the engagement, relax. I'll go another baby step, press against me. And there's the engagement of the muscle. Relax.
He's having, right,
And I would continue this all
he's
the way
moving
over
her,
to the greater
the foot
trochanter.
medially, and she's,
That's palpation
right,
of the
she's
piriformis
restricting
muscle
it.
and gel musculina.
right, it's side to side, right. So that's the movement, right? So he's engaging and she's resisting, right? Actively resisting it, and that, okay. And that's what gets it to stand up. But if the resistance was too great, then she'd engage the glutes. Right? Okay. Is that good? Is that worth?
I actually felt I marked it and everything.
Sorry?
I like that.
Yeah, I thought you would. I saw it. I said, yes, that shows it so well. He is an authority in the field. When I see stuff by him, it's worth. Huh? Okay. So when so as I said, when you're downstairs later and you're working on doing your Swedish, take the time. What's that? Muscolino. His name is Joe Muscolino. Muscolino. I have a number of he's written textbooks, and he really is an authority in the field. He lectures, he does CEUs. And Joseph, yeah. Joseph Muscolino. Yeah. Some of his stuff is a little dense, but he's good. Okay. Anything else? Let's close this. Okay. Let me see if there's. Does this help just in terms of seeing what the muscles and some of the other muscles are looking at, or is this too difficult to
That's good.
see? It is good?
Yes.
Okay. So I can make it a little larger even. So they've got all the adductors in here. Or the rotators, rather. And some adductors. The deep rotators. Let's see. All right,
A
now.
lot of videos in his website.
Oh, his website. Yeah. Well, you want to go there and see if there's more? Yeah, he's got. It was the only thing I really looked at in terms of YouTube. But for sure, there's tons of stuff out there. That's why do look at YouTube Abhyanga just to to satisfy your curiosity, since we're going to be dealing with it on Wednesday. Okay. That was a link to email to myself. And this is what we just looked at. Okay. Oh, I'm sorry. No, there's more. Let's see. This guy wrote a piece on piriformis syndrome. Now he has this on iliopsoas tendinitis or iliopsoas syndrome, and he maintains that he says they're two separate conditions. The tendinitis is simply inflammation of the iliopsoas muscle, which is really two muscles, the iliacus and the psoas. And if you've got if you have Segan-Adams, iliopsoas is in here, you're dealing with the psoas major. Let's see if we show here. Oh, this is good. Okay. Psoas, not minor. The minor is absent in 60%, no. Yeah, 60% of the population doesn't have a psoas minor. So don't worry too much about that. The psoas major originates on the T12, right? Lumbar to L5, right through.
Yeah.
Okay, 1, 2, 3, right? And then the iliacus is originating on the anterior surface, is it? I think, the inner surface of the ilium. Right here. Does this help? Does seeing this, I hope? Yes, no, maybe? Tell me. Okay. I need feedback, folks. I'm working with this technology, and it beats, in my opinion, my standing up here and just droning on about the same thing in front of you. Okay. Together, in any case, they insert on the not greater but lesser trochanter of the femur, right? So what do? What action do they perform?
Adduction. About the inner, which muscles you're talking about?
They're inserting on the lesser trochanter, right? So what they're doing is they're flexing the hip, flexing the femur at the hip joint, right? The psoas is, for all intents and purposes, oh my God, no, we're finished with the piriformis. I'm talking about your muscle, because you're dealing with it with iliopsoas syndrome or whatever that, you're working with it. It's the strongest hip flexor in the body. Or they are, even though, again, we refer to them together, they work together. Lifting they call it here, the upper leg. This is layman's terms.
Well, that's why the little marionette thing on the thing shows you.
Yeah, and I'll switch to that. I just thought I don't know. I took the time to find a few things, and I think this helps you see it in other ways. The marionette thing is animated. What I really want to get us is some cadaver videos. There's one guy who does.
The one with the hat?
No, not with a hat. I mean, he's working Dr. Ackland's anatomical dissections. I mean, you see everything.
I know, I've seen that.
Yeah. So hopefully we're going to get those.
It'll be gross.
Well, it depends on how you feel. I don't
Yeah.
find it gross. If you don't like blood, then it's stay above the skin.
It's not even blood because it's the calipers have been
Huh?
immersing.
Yeah. Anyway. Okay.
Tenderloin and the filet mignon.
Yeah. No,
That's-
that's not the filet mignon.
That's the tender. No, I think he's right. It's the tenderloin. The filet mignon is
The long, slender psoas major.
right. The major. Yep. And the tenderloin is the iliacus. Maybe. I'm not sure about that piece of it, but absolutely.
It's not this one running on the side of the spine.
It's
The filet mignon.
no. You're dealing with no. Nice ham, nice. The loins, which is to say the thigh in us. Okay, let's see. What causes the tendinitis?
I'm gonna find out.
He maintains again that you've got iliopsoas tendinitis and iliopsoas syndrome, right? Tendinitis being caused by repetitive hip flexion or overuse. Therefore, any itis is inflammation, right? And the syndrome caused by a tear, a rupture, sudden strain, right, of the muscle or tendon, right? Usually some sort of athletic accident, or it could be a trauma, blunt force injury, I suppose. Athletes at risk. What athletes aren't it? People kicking, the soccer players, hey, the World Cup women, give them credit. So he talks about symptoms. If it's just tendinitis, the pain will begin gradually. If it's the syndrome, it's sudden and very sharp, which makes sense. What do? Rice, 48, first 48, 72 hours would be, afterwards we'll do heat and massage, right? What can you do to prevent it? He's big on stretching, which makes a lot of sense. Stretch before, stretch after. You would certainly agree, right? Too many people go out and they do, or is it a static, or they need to do a static stretch first and then an active stretch afterwards? Is that, no, it's just the opposite, right? The active stretch first. I remember when I first came in here, I talked about it. Active stretch and then static, cooling down the muscles after the activity, right? Thank you, Rebecca. Called ballistic stretching. That's the active stretching is ballistic. Yeah, because you're moving, right, right. Yep. Mm-hmm. Right. Okay, rest, and here's his stretch. I'm sure. Does that make sense? Hmm? Well, she'd be, whoops, there. And you can get a 23-page stretch. There's a lot of free stuff out there. I ordered it today. I didn't have a chance to look at it, but it's on my computer at home. I mean, obviously, he wants you to buy into all sorts of other stuff, but you don't have to do that necessarily. Okay, all right, let's go to, ta-da. All right, there's our lateral, doesn't look it, but that's our lateral rotation.
That's piriformis.
This is the piriformis, right? Look. Okay, all of them, same thing. They're all working together. They've got, they don't have all 6 of them, but they've got most of them there. So.
Just 4.
Yeah, just 4. There are 2 others down here. He's got quadratus. From top to bottom, it's piriformis, gemellus superior, obturator internus, gemellus inferior, obturator externus, and quadratus femoris. That's from superior to inferior. And there's an acronym for that. Piece goods often go on quilts. We'll get to that. Huh? We'll get to that next module or next course. Okay, what does it say? External rotation, it's a hip stabilizer, or they are. And again, my concern was with the piriformis. Okay? And there. Anything else you want to... Oh, let's go to the... whatchamacallit? The psoas. Let's see.
So where would you palpate for sciatica?
Okay, I would palpate, right, from here, right? And I could strum across. I've seen people suggest that you strip the muscle slowly, right?
That's the piriformis.
Yes, this is the piriformis right there.
Because the sciatic nerve.
Because the sciatic is
it's underneath it, right?
yeah, underneath it. It might go pass through it. It might be.
Doesn't it wrap around the femur too, though?
The sciatic, yes, yeah. So again, there are other nerves that could be impacting it, but this seems to be the most common nerve that's impacted by this
Muscle. Yeah.
muscle.
Yeah.
It's common enough that people have done, the likes of Whitney Lowe and Muscolino are writing about it and treating it. So when I'm working it, I'll often find that there are, he talked about coming across, right? When he did the, he'd be dropping down to the apex of the sacrum and then going out, right? You need to get off of the sacrum itself. So I would say here, or sometimes here, you'll find trigger points, a trigger point. And you'll feel it. Sometimes I'll go in there with a thumb, sometimes I'll use an elbow. But sometimes I use an elbow, definitely during that lateral rotation with restricted move with what's the term? Resistance by the client. Slight, not too much resistance. Okay. So while you're rotating the piriformis, your client is pressing against you. Okay. Now. There. Okay, here's Rebecca's. Wait a minute, where are we?
Yeah, the sauce.
I had it.
Problem with the sauce. That's the tenderloin. I
Sorry?
just found the information.
Ah, there it is, the tenderloin. Yep.
The sauce mayo.
Where are we? Sorry about this. Here. Yes, okay, finally we got it. Okay, so you have the muscles together, right? Right? The iliacus originating from the anterior surface of the ilium, right? The psoas major from T12 to L5, right? And the insertion right here on the lesser trochanter, not the greater trochanter, the lesser trochanter of the femur. So let's see what it does.
Flexion of femur.
Right, it's flexing, and it does look like an abduction as well, right?
It's flexion of trunk.
Right, it's flexion.
lumbar
Yeah,
spine.
it's flexion of, what does it say? The trunk on the femur, right?
Uh-huh.
Right. If the thigh is fixed, that's what we do. Right. If the thigh is fixed, let's see. You do a sit-up with it, right? Lordosis, tilting the pelvis. And there's your hip lateral rotation. So it assists there. Essentially, I see it. So if the thigh, if the thigh is fixed, then it flexes the trunk,
Uh-huh.
right, at the hip joint. And what else flexes the trunk? What other muscle?
Mm,
Flexes the trunk.
Trunk. Mm-hmm.
The maximus.
Flexes the trunk. Come on, what do we do? What are we using here? Right, your abdominals. Right? Your rectus abdominis. They're keeping you, right? What else? Come on, I'm not going to give you, I don't want to give you all the answers.
some muscles in the back.
Well, most of the muscles, right, are extensors, right? In the back. Right? Posterior on the back are extensors, or there are lateral flexors involved as well. But your flexors, as far as your trunk is concerned, and your lower extremities are in front, are abdominal, are anterior. Same idea here, right?
So this is a flexor. but
For a
it's not-
flexor of the femur, it's not a flexor of the lower leg. Yeah, go ahead. What was your
But it's
question?
not really, it's not anterior or posterior, it's lateral.
Yeah, it's more. It's
On the
a.
side, so
What do they call it?
So
Sorry?
if you change the rule, which would be basically that if it's posterior, it's an extensor, and if it's anterior, it's a flexor.
It's on the side. Yeah, right. So there's a little variation to the rule. Good observation.
So then is there an extensor on the side also? The,
Well, Yeah, so
Guys, thanks.
yes, no. You got the quadriceps group, of course. That's for the knee. You got the flexion. You got your adductors. No, they're adducting. I don't want to spend too much time on the lower extremities because we have to do the. That's not until until September, right?
I'll look it up, I'll figure it out.
Yeah. So I just figured that we were here, we were interested, and let's see, here's your iliacus. And again, both.
And now we know where the filet mignon is.
Now we know. Okay. Where's the New York strip? Okay. Now I'll keep this here. I'll move to the upper body and okay. And then where do we want to start? Where did we leave off last week in terms of the flexors and extensors, the forearm muscles? Laundry? You don't have to do every... Are we clear on the muscles coming off the shoulder, the biceps? Do you want to see this again as we move down the arm?
Yeah.
We have time. We have plenty. We've got a few weeks to really go over. So I figured we got the back, I think, and the trunk muscles down. And if we don't, we'll have time to review those too. So let's start back at the shoulder, and we'll work our way down, starting with the biceps. I may bounce around a little bit. I like working through this book with muscles in motion, okay? And if I'm overlooking any muscle, if there's one you want me to take another look at, please speak up. Okay, what are the biceps? The bicep. We know why it's called biceps?
Yeah.
Right? Two heads, right? Triceps. Okay. So what does it do? Where are they? You got a short head, ta-da, right here, okay? Which originates on what? What's this? Where's the origin? Where is it? It's probably telling us. On the bird's beak. Remember the coracoid process? Right? Right? Pec minor also connects there. If I'm correct. Coracobrachialis starts there.
Coracoid process.
Right? Okay. So the short head flexes the humerus, right? We'll show you in a minute. Okay. Let's see. I don't want to see elbow flexion. I want to see shoulder flexion. There. Okay. Short head is doing that. A whole bunch of other things that they're doing. Essentially, I see the short head as being a shoulder flexor. Right? They're going into more detail, but I see it as shoulder flexion here. There, bing. Right? They'll tell us that it also is involved in shoulder adduction, right? Horizontal adduction, rather, and adduction in general. Okay, forearm supination. It is, yes. We know there's a supinator muscle, right? In fact, there are two, and one of your major supinators is the biceps brachii. Right? Now let's see, the long head. Did I miss anything else here? We got the forearm supination, right? Okay, what's happening with supination? What's moving? What not the muscles, what bones are moving? What's happening? And what's,
The radius and the humerus.
right? The radius is moving.
And the, what is it? Not the ulnar.
Right.
Ulnar.
Yeah. The radius is rotating over the ulnar,
Yeah.
right? So, supination, and this, so the muscles are the supinator, which I will get to in a minute, and I believe it's the short head, yeah, the short head of the biceps brachii. The long head, also elbow flexion with supination, forearm supination again, because both heads are involved there, assists in shoulder flexion and shoulder abduction. Okay. When laterally rotated, okay. My concerns are the action is flexion of the elbow, supination of the forearm, and both assist in humeral flexion. Or the short head is in humeral flexion. Let's see, they both elbow flexion, forearm supination, shoulder flexion, long head, shoulder flexion. Okay? Let's see, the brachioradialis. What is it? What's it cross? Just as soon as you see the joint that it's crossing, you know what it's going to be doing. The muscles that it's attaching to. Right? Right? It's an elbow flexor, right? It's anterior. It originates on the humerus, right? In this lateral epicondyle, supracondylar ridge, right? Lateral side here. And if you flex this, let's see, I think it's in a neutral position. Yeah, with forearm in neutral position, you can, with resistance, you can palpate. You can see it. You see how it pops right up on me, right there. You try it. Take your arm, put your neutral position, not horizontal, just a neutral. In other words, this is anatomic position, right? So neutral position is you're not supinated, you're not pronated. I see it. This is a neutral position. Try flexing the elbow with resistance, and look what pops up. And you can palpate it and see what's there. I want you to do it not only on yourselves, but when we're downstairs, these are the ways to figure out. And obviously, there are so many more. When you're working on them, you're not necessarily going to be thinking, well, which one is this? Their flexors and their extensors. But for the sake of, well, for argument's sake, unfortunately, you do have to certainly know some of these, most of them. Okay? So here's our pronator as well. Anything else I could tell you about brachioradialis? Yeah, flexion of elbow with forearm in neutral position. Yep, there's your neutral position. Okay. What else? I want to look at the brachialis. I'm covering eventually all of them that are on the list that she handed out. It will not be all of the intrinsic hand muscles, but everything coming down from the forearm. Okay, brachialis. What's going on with the brachialis? Origin is lower distal half of the anterior, right? It's got to, if it's anterior, it can only be doing one motion, right? As far as extensors are concerned, is there anything other than the triceps on the upper extremities? No, that's it. Those are your triceps are your extensors. Sorry? Well, they're extensors for the hand and for the wrist, but that's for the upper arm. That's it. So, yes, what is it doing? It's an elbow flexor. Right? The insertion is in the tuberosity of the ulna and the coronoid process of the ulna, if you say so. I know it inserts on the ulna. Okay? Coronoid process and the tuberosity. All right, let's see. Should I use my list? It doesn't matter what order I go in. Okay. What else? Come back here.
Oh, that machine took my money. Did you get your check for free? No, no. Took my damn $1.25 and said, okay, 25 cents, give us. Oh, yeah. People heard my car down there.
There's my coracobrachialis. Ah, here we go. Okay, coracoid process. Remember the bird's beak? Okay, so what's it going to do? That's our origin. It's inserting here, right? Middle shaft of the humerus, right? Middle third of the medial surface of the humeral shaft, according to Segan Adams. So it's a shoulder flexor. And let's look at it. What else can it do? Here's our flexion. Here's our adduction, and of course it's going to move across. There's your shoulder horizontal adduction or adduction. Okay. All right. I will get to the triceps. I just want to cover. Well, it's nice that it's alphabetical, so to speak. Okay, right, you've got an anterior, middle, and a posterior deltoid, right? Why is it called a deltoid?
It's a triangle.
Shape, thank you, yep. Shaped like a delta, sort of like a triangle.
What is the delta?
A delta. So what does it do? It originates on, you've got three different origins, right? Anterior is originating on the lateral, right? Lateral third of the clavicle, right? Middle is originating on the
Scapula.
acromion process, right? Okay, posterior originating on the spine of the scapula, right? That's what it says up here. I'm looking in my book. I'm not reading it off the screen. So let's see what it does. It's a shoulder abductor, right? Abductor, but only to a point, right? It will abduct the shoulder to 90 degrees. How do you go beyond 90 degrees? What are you using? What's up here? What's above it?
Traps.
Well,
Subscapular.
supraspinatus, right? That's what's.
Your traps aren't helping at all?
Shoulder, yeah, your traps are helping, but not for.
That's for lateral versus.
No, I don't think so. Let me take a look at that. It's a good question. Let me see. No, you're basically, with the traps, you're dealing with the scapular upward, scapular elevation. You're not dealing with humeral because it's not crossing this joint, right? Think about what, it can't have an effect on the humerus because there's no insertion on the humerus. Yeah. So for anything to have any effect, you've got to think, okay, what joint is it crossing? Right? Nothing's going to move unless two joints are crossed. At least a joint is crossed. Now, it could be more than, depending upon the muscle, could be more than one joint, in which case that's where you could be dealing with flexion and extension. Anyway, different things. Now, the thing about the deltoid is the anterior and the posterior are antagonists, right? Because look at what they're doing. Okay, anterior is the shoulder abductor. Posterior is, no, wait a minute. So I'm wrong. Yeah, they're both abductors. My notes tell me otherwise. Let's see. Where am I? Okay. We know the insertion is all the same, right? 1, 2, 3. What's this called? Where it's inserting? Well, but where on the humerus? There's a bony landmark, a prominent, you could feel it. What's it called? It's a tuberosity. It's the deltoid tuberosity. Okay. Got it? Okay, that's inserting on the deltoid tuberosity. So the action, anterior will flex to horizontal adduction, medial rotation. Posterior is an extensor, horizontal abduction, and lateral rotation. That's where they do act as antagonists, right? Just like the trapezius, the upper traps are elevating, the lower traps are depressing the scapula. Okay, let's see. What else can I tell you about it? The muscle form. It's a strong abductor, but it can't initiate the movement because the angle of the pull, you need the supraspinatus to initiate that movement. Let's jump down to supraspinatus. And there. Okay. Right. It's a scapular stabilizer. And without it, the shoulder wouldn't, let's see. Doesn't show it going up higher, but I know that it does, right? The full, what does it say? The full can position, abduction with external rotation has been shown to be more optimal position for supraspinatus isolation. That's too isolated. Okay, back up to the deltoid. Okay. Moving down. Let's see. I will get to the triceps. We did the coracobrachialis, right? Just did that? Yes. Okay. You want to take a look at the sits muscles again? No. Okay, good, then we won't. Subscapularis. No, we're good on those. But let's look at the pec major and minor very quickly. Pectoralis. All right. You've got a clavicular head, you've got a sternocostal head, even and have an abdominal head. And everything is inserting on the intertrabecular bicipital groove and the greater tubercle of the humerus. Let's see what it does. Shoulder horizontal adduction, shoulder medial rotation. You see how it's pulling, turning the arm? And shoulder adduction. Now, pec minor originates on the coracoid process, the bird's beak. Right there, looking at it on the left side now. Going to protract the scapula. And it insists in inspiration. Okay, what else? My list. Going down the arm. I'm not going to do the. Okay,
The pectoralis minor is underneath.
Yes, yeah.
Is it attached to the major in any way? Or does it work independently?
It's, let's see, good question. Because the pec minor, right, is protracting the scapula. The pec major is adducting. It's medially rotating and adducting. You got horizontal adduction and general adduction. So no,
So they kind of just glide.
right. They're acting because the minor is not connected to the humerus at all. Right. The minor is connecting to the coracoid process from the three. Look, the three ribs. Right. What is it? Third, fourth, fifth, right? Third to fifth ribs, coastal cartilage of the ribs. So it's a protracting the scapula, not retracting. What are the scapular retractors? You want to go back in this direction. What's in the back? What's pulling them back?
Is that the teres knife?
Okay. Teres. What else?
Traps.
Let's look. Right. Nope. What about something's going to be pulling not from the humerus? If it's retracting the scapula, it's going to be pulling from that. What? The rhomboids, exactly. Exactly. Thank you. Anything else? Let's see.
Traps, right?
Mm-hmm. Hang on. So here are the rhomboids, right? Right? They're calling it scapular adduction, right? Which is to say retraction, right? In addition, you got some elevation, downward rotation. Okay, the trapezius, I like this. We can toggle from one to another. Right? There you go, more adduction. So the traps, the rhomboids, what else? What else? Those, I guess, are the two major scapular adductors or retractors. Okay. Let's see. Okay, what's happening here? This little muscle. Oh, I didn't. Anconeus, I want to get you the serratus anterior to remind you of that too, but while we're here, okay, what's this? A little muscle. It assists in some extension of the elbow. Okay? Right. Lateral epicondyle of the humerus, or insertion is on the lateral side of the olecranon and the shaft of the ulna. So it's an elbow extensor. It's pulling it back. Okay. Okay, let's go. Okay, now what we're gonna, they're calling this abduction, I'm calling it protraction. Right? All these saw-like muscles originating on the ribs, the first 8 or 9, and inserting on the scapula. Coastal surface of the medial border of the scapula.
God bless.
God bless. Sei gesund. Okay. Okay, remember our supinator.
Are you cold? Go on the corner, it's 90 degrees.
Right, it's turning the, rotating from the lateral, could only be a lateral epicondyle origin, right? And inserting on the radius, and it's going to rotate, pivot that radius around the ulna. And what's the other supinator? Remember? We just talked about it. We looked at it. It has 2 heads.
It's a bicep.
Biceps, right? Okay. Biceps brachii, and I believe it's, both heads. Okay. We did coracobrachialis. The 2 pronators, and then we'll turn to the triceps, and then we'll work our way down the forearm and into the hand. Okay. And I know I should give you a break, but hang on. What did I say? The pronators. Okay. Okay. Pronator teres. You got 2 origins, one on the medial epicondyle, one on the coronoid process of the ulnar, right? Inserting in the middle of the lateral radius, right? About halfway between. So doing that, coming from medial, right, epicondyle to lateral surface of the radius, what's it going to do? Pronate the forearm, right? Turn it down, right? Soup, no soup, pronation. Also assists in some elbow flexion, makes sense, right? And then that's the pronator teres. There's one down here. There's another pronator we are about to look at. Pronator quadratus. Right, so you're dealing with the origin on the distal ulnar, inserting on the distal radius, pulling the radius this way, right? Let's look at it. Bingo, whoops. There we go. Soup, no soup. Okay, pronation. Okay. So forth. All right. Now, our one extensor, let's find it. Come on, here we go. Oops. Okay. Three 3 heads. Okay, do we see all 3? 3 heads. The long head origin is on the scapula. The right, glenoid tubercle of the scapula. Inserting on, just as the olecranon of the ulna, right? There's your insertion. I think they all insert in the same place. They all do, right? Lateral head, medial head. Medial head originates on the shaft of the humerus. The lateral head also on the shaft of the humerus. It's only the long head that's crossing this joint, right? Because it's going from one side of the shoulder to the other. It's originating on the scapula, right? So the whole thing, long, lateral, and medial, would act to extend the elbow, right? And let's see, the long head, because it's crossing here, right, could do what? It's crossing the shoulder joint, right? So what action could that, there it is. There, the long head is extending. I don't know, is it showing it there? I don't.
That's not the long head.
Here, that is right there. Long, right, wait a minute. Yeah, this is the long head, right? Because it's extending because it's crossing the shoulder joint, right?
So is his hand supinated?
No, it's an extensor of the humerus, as well as as well as the elbow. They all extend. They all insert into the olecranon process of the ulnar, right? So that's where you're getting your elbow extension, right? But the long head, right? Since it's here, it's crossing the shoulder joint. Therefore, it assists in shoulder extension as well, right? Extension of the humerus. By shoulder, I mean the humerus, right? Okay. Make sense?
Yes.
Okay. 3 heads, better than 1. Better than 2, I'm not sure. Okay, anything else? Let's see. So that takes care of the muscles that are crossing the shoulder joint, right? And crossing the elbow, right? Now, we want to look at,
What's the action of the medial head again?
the medial head is the elbow, just the elbow extension. The action of the medial head and the lateral head would be the same. Because because the action, again, think of it this way. The origin is right on the olecranon process of the ulna, right? Right there, right? Right, it's pulling, right. When it contracts, it's extending the elbow, the forearm, right? At the elbow joint, right? And the long head, because it's coming from here, right? Inserting the same place, it's also extending the elbow, right? And it's able to pull back the humerus. It's a humeral extensor as well.
Oh, okay, gotcha.
Make sense?
Yes.
Okay. This is how I explain it, right? By showing you on me up there, and then you can. Yeah. I mean, you can only read it. I like, all of the above.
It helps in the extension of the shoulder.
Right, because it's crossing, whatever joint it's crossing, it's going to have an effect. So in this case, the long head is crossing 2 joints. So it's going to extend the forearm at the elbow, extend the elbow, right? As well as pull back on the humerus because it's crossing right here. Humeral. Inserting in the same place, but that third head makes a difference. Okay? All right. To the forearm and hand. let's go with our flexors first. And I don't care which order. We'll go with, I'm going to go with her order on here, right? Oh my goodness, okay. Well, I don't want to hold them, I just wanted, okay, let's go. Flexor carpi ulnaris, there it is. Okay, this is kind of nice. There, we got a whole bunch of them all together, all the forearm flexors. Wrist and finger flexors. I hear the book with forearm and hand, okay. So taking them one at a time, and let's see, her flexor carpi ulnaris, what's it going to do? Originates, oh wait, let me get my book here. Okay, it's got a humeral head, right? And an ulnar head. So if it has a humeral head, we know it's a, well, let's see, it's a forearm flexor. It's crossing the radial, ulnar, the elbow joint, right? So what's it going to do? It's going to adduct or deviate. It's a wrist flexor, right? What does the name tell us? I'm looking at flexor carpi, right? I'm going into order. Flexor carpi ulnaris, right? Carpi is wrist. And you got flexor carpi radialis. Same idea. It's a wrist flexor. Let's see, we're also abducting the wrist, right? The ulnaris would be adducting the wrist. You see the difference, right? Because one is coming from the ulnar side, right? They're both flexors. One is going to be in the ulnar side is going to be an adductor of the wrist, aka an ulnar deviator, right? Does that make sense? Okay. And the radial side is abducting, taking away from the midline, or radially deviating. It's a radial deviator. Okay. All right, let's see what else. Palmaris longus, another wrist flexor, right? The difference, superficialis and profundus. Profundus is deeper, okay? And what you find is with the digitorum, the deeper, the profundus, I believe, dives underneath, yeah, the superficialis. I don't know if you could, to get to the, let's see, if we see, you don't see it here. Maybe you do, wait. Yeah, you see how they break into two pieces here at the end? Sorry. Right here. The profundus is going to reach all the way to the distal phalanges, and the way it gets there is it dives in between those two pieces here where the superficialis splits. See, the profundus, it shows it a little bit better in the Segan Adams, I think, but this is kind of nice. Okay. Did I cover them all? Let's see. 4 insertions at the base of the distal phalanges. And it goes underneath, it dives underneath the superficialis. Okay, flexor carpi radialis, we got that. Digitorum profundus, palmaris longus. Okay, those are our flexors. Forearm hand flexors. Let's see what else. Flexor, yep. All right, let's look at our extensors. I think they'll probably give it to us all together again. Yes, okay, good. So all of them. What are they doing? The name tells us, right? Right, they're all extending the wrist. What does it say? Every muscle motivate the joints. Whoa. Okay. There's a language problem here. I'm not sure what they mean by motivate the joints. Yeah. Okay, so let's look at the extensor here, okay? Digitorum, extensor carpi, radialis longus, right? So that's going to be inserting on the radial side, right? Probably the first two, right? At the the metacarpals, first two, not the thumb, the second and third metacarpals, right? You see? Okay. That's okay. Which is brevis? Which is longus? One's a little shorter than the other.
This one?
It's longus, brevis, and we can see what they. Whoops, sorry. Oops, extensor carpi radialis, wrist. Sorry, wrist adduction. A wrist adduction is also called. What is another term for adduction of the hand, the wrist? Adduction, we're moving toward the midpoint, right?
Medial deviation also.
Adduction is ulnar deviation. Right, think of it again. All in anatomic position. Adduction is ulnar, right? Right? Abduction is radial deviation. So just think of which bone, which side which bone is on which side, right? Your medial is the ulnar in anatomic position, right? Okay. I mean, they're all doing the same thing, right? Now, extensor carpi ulnaris tells you it's on the ulnar side, right? Extensor carpi radialis, you got two of them, one brevis, one longus. Extensor indicis, what does it tell you? The index finger. Okay? So in so many cases, the names tell you what's going on. And most of these are all ending in tendons, right? The muscle's not. One of these, if I recall, is actually used for tendon replacements, one of these forearm muscles. Anyway, okay. What else? We've got our, did I miss any of them? The flexors and extensors? It's nice to have them all together. You want to look at them again? All right, extensors extend, just in terms of seeing where they go, right? Right, the 4 digits, not the thumb, right? So if it were the thumb, what would a name be in there? Pollicis, right? Pollis something. So let's get away from the digits and look at pollicis, brevis and longus, right? Right, beginning here. Let's see. I need my reading glasses. These are the muscles on the hands. Let's see. The abductor pollicis brevis abducts the thumb. Assists in opposition, extension, flexor pollicis, right? What's it going to do? Is there a flexor pollicis longus? Let's see. There's a brevis, and there's a, I don't think so. Yes, there is. Sure there is.
I don't know if they give us flexor pollicis brevis. Yes, they do. I'm on it. So where's flexor pollicis longus? Come on. Ah, okay. That's not intrinsic. And that's extending to the distal flange of the thumb. So brevis is to the proximal phalange of the thumb. Okay? Make sense? Yes, no, maybe. Okay. Let's see. Oops. Pollicis longus, extensor pollicis brevis, pollicis extensor pollicis longus and brevis, and flexor pollicis longus. All right, it's just a question of which side of the pollicis it's inserting on. Whether it's a flexor or extensor. You know, which side of the forearm are these coming from? Anything else? I want to give you a break before we go downstairs, or maybe on the way downstairs. All right, I haven't gotten into the digity. Let's leave that for tomorrow. All right, because we got the hyperthenar eminence, which is the opponent's digity. I can show you the hyperthenar eminence, but we'll go over it. We'll look at it tomorrow. Let's see if they, I don't know if they list it by here. Probably not. There you have your flexor digiti minimi. Oh, they do have the hyperthenar eminence, yeah. And then you've got your extensor, your flexor, your opponent's digiti minimi, ouch. Oh, there's your opponent's pollicis. Here it is, okay. You have when we talk about the thenar eminence and the hyperthenar eminence, right? Your thenar eminence is here. It's the thumb. It's below the thumb. It's the fleshy palmar side of the thumb. That's your thenar eminence, and there's a series of muscles that we talked about. She definitely lists here. The hypo below the thenar eminence, right, is next to the digiti minimi, and the two are going to combine for some opponents, some work toward one another. From the thenar eminence, you got opponent's pollicis, and the hypothenar eminence, you've got abductors, opponent's digiti, right? Opponent's digiti minimi. In other words, the two muscles together from the thenar eminence and the hypo below the thenar eminence will allow that oppositional action to take place. Right? Should I show it? I was reserving this for tomorrow. Why do I keep talking?
We're going to be reviewing the hand tomorrow?
Yeah, we're gonna take our time with the hand tomorrow. Okay?
Oh, good.
Right, yeah, this is a lot. So that's why, again, we have plenty of time. We're not doing the lower extremities until September. Okay, so we really have a lot of time to review, to really go get into the hands. Some of the hand muscles, the lumbricals, things like that we won't deal with. Don't have to deal with. Though you should know they're there. Okay, let's call it quits up here. Choose a partner, take a break. We've got plenty of time to do some Swedish, okay? You've heard me ramble on for far too long. Okay? Yeah, we're going downstairs. We're going to we are taking a break, and in the process, we're going to do Swedish. And you can palpate some of the muscles that we're talking about.
Good job, Nick.
Let me turn this thing.